Hi friends, welcome to this platform where I will be discussing some high yield multiple choice questions which are on topics which I feel are very important topics for your upcoming NEET PG exams, which are scheduled about a week from now. Uh, the topics that I will be discussing in this section will be topics which I feel are very important, and we therefore have come out with these 10 questions which should test you also. And in case you have not gone through these topics, please do go through these topics. These are very important topics for your NEET PG exams. The first question is on seizures, which is a very important topic for your NEET PG exams, childhood seizures. And we'll discuss the first question. The first question is a case of a 3.5-year-old boy who is brought to the emergency with a history of generalized tonic-clonic seizures since the last 6 to 7 minutes. So the child has been having generalized tonic-clonic seizures since the last 6 to 7 minutes. The child is a 3.5-year-old boy. The question that they are asking is, which of the following anticonvulsants is the last to in the order to be chosen? So you many times will be asked the question, which is the first anticonvulsant to be chosen? But suppose a child does not respond to anticonvulsant and the child keeps on seizuring. In those cases, then there is a sequence that one needs to follow of the subsequent anticonvulsant. So basically, if the first line anticonvulsant does not work, the person or the pediatrician has to move on to a second anticonvulsant. If that does not work, the person has to go on to the third anticonvulsant. So what is the recommended sequence? Although any of the anticonvulsant drugs can be chosen to abort a seizure, the sequence that you should generally follow when a child comes to you with a seizure is this. See, the first and most important thing is that you have to first rule out the cause of a seizure. So first, identify what's the cause of a seizure. Say, for example, if it's a metabolic abnormality, a hypoglycemia or a hypocalcemia, then you have to treat that. In case it's a meningitis that is causing a seizure, then you have to start the treatment for meningitis. The basic thing that I would be discussing here is focus only on a seizure in which metabolic abnormalities have been ruled out, and now you are giving an anticonvulsant to abort a seizure. The first line anticonvulsant that should be given to abort a seizure in a child usually is either an IV lorazepam or an IV midazolam. So barbiturates are usually the first line treatment options that should be given to abort seizures, and either 0.1 milligrams per kg of a lorazepam loading dose or a 0.1 milligram per kg of midazolam loading dose can be given to abort seizures. In case the seizure does not stop after giving one dose, you may repeat the second dose 5 minutes later. Now, once the seizure continues, even after giving IV lorazepam or IV midazolam, you can choose one of them. Then the second drug that you should choose is IV phenytoin or IV fosphenytoin. 20 milligrams per kg of dose needs to be given, IV phenytoin or IV fosphenytoin, 20 milligrams per kg. And in case the seizure does not stop, even after giving 20 milligrams per kg of IV phenytoin or IV fosphenytoin, then 10 milligrams per kg of additional dose may be given to abort that seizure. Now suppose even after giving phenytoin or fosphenytoin, the seizure still continues. Then the next drug that should be given, the next anticonvulsant that should be given to try and stop those seizures should be IV sodium valproate. The dose of IV sodium valproate should be about 20 to 40 milligrams per kg, and it should be given only after giving IV phenytoin or fosphenytoin, and if the seizures still continue, then 20 to 40 milligrams per kg of IV sodium valproate needs to be given. If still the seizure continues, the next line drug that should be tried is IV levetiracetam, and this should be given in a dose of 20 to 60 milligrams per kg, but should be given as slow infusion of 5 to 5 milligrams per kg per minute. So the dose is 20 to 60 milligrams per kg, but should be given in the form of slow IV infusion at 5 milligrams per kg per minute. And believe me, most of the time, by this time the seizures usually will stop in the children. But suppose the seizures still continue, they have still not stopped, then the subsequent choices will be either IV phenobarbital. Even after giving IV phenobarbital, if the seizure is still not stopping, then you might go in for a midazolam slow IV infusion in the ICU. And this IV midazolam infusion can be given at a rate of 1 to 15 micrograms per kg per minute. So you can give a slow IV midazolam infusion in case the seizure does not stop even with phenobarbital. And I'm sure you do realize that by this time the child is now a quite sick child, and the child already is in a status epilepticus. In fact, if the child does not respond to seizures, to anticonvulsants, the seizures do not stop, even after giving 2 or more anticonvulsants, then we call those seizures usually as refractory seizures. So refractory seizures by definition in children are seizures that do not stop or fail to respond despite giving 2 anticonvulsants or more. Don't confuse it with a super refractory seizures or super refractory status epilepticus, which is actually a status which continues for more than 24 hours despite giving multiple anticonvulsants. A refractory seizure or refractory status epilepticus is when at least two anticonvulsants have been given and still the seizures are not stopping. So always go in this sequence. Start from lorazepam or midazolam. In case the seizure do not stop, a dose need to be repeated in 5 minutes. If seizures still do not stop, you may go in for IV phenytoin or fosphenytoin. If the seizures continue, go in for IV sodium valproate, then go in for IV levetiracetam, then go in for IV phenobarbital, then go in for IV midazolam slow infusion, and then subsequently you may go in for other drugs which actually will be reserved only for refractory seizures, such as oral topiramate or IV ketamine, and subsequently vagal nerve stimulations can be tried or surgeries can be tried for refractory seizures. So if we go back to our question now, lorazepam and midazolam, obviously as I just now told you, will be the frontline drugs to treat a seizure or to abort a seizure, followed by the use of phenytoin. So phenobarbital, according to me, is the last in the sequence to be given. First you should give lorazepam or midazolam, then phenytoin, then sodium valproate, then levetiracetam, then come to phenobarbital. So the sequence in which the anticonvulsants drugs should be given once the child comes in continuous seizures or a status epilepticus should be well known to you. Let us come now to question number 2. Now question number 2 is a question which is again on a very important topic, which is meningitis in children. Question number 2 is of a case where a 4.5-year-old child has come to you with a fever, neck stiffness, delirium and petechiae. So there are petechial rashes along with signs of meningitis in the child, including fever, neck stiffness, delirium, and the child has been brought in the emergency. The child, according to the parents, had fever since 2 days and since then has rapidly progressed. Now this is very important. The child has rapidly progressed to the present state. So he was having fever for the last 2 days, and from that fever since 2 days he has rapidly progressed to neck stiffness, delirium, and now has developed those petechial rashes all over the body. Examination findings of the child revealed tachycardia, a thready pulse, a prolonged capillary refill. A prolonged capillary refill usually indicates the child is in a state of shock. So that can be done by just pressing the child's chest, and then you can leave the chest and you can see the area that has been blanched, how quickly that color refills again or color comes back to normal. And usually that takes 3 seconds or more, it indicates that the child has a prolonged capillary refill time, which indicates that the child is in a state of shock. Plus, there were non-blanched rashes also that could be seen. So, any child who has fever, neck stiffness, delirium appears to be in a case of meningitis, first thing. Second thing is, meningitis in children can have many causes, but this child appears to have petechial or non-blanched rashes also and has rapidly progressed to shock. So now I have 3 things in hand. A child who has fever along with neck stiffness and delirium, so meningitis. The child has petechial or non-blanched rashes, and the child has rapidly progressed to a septic shock. All of this should fit into a picture, according to me, of meningococcal meningitis. So now the question that is being asked is, which of the following statements about the potential cause of this meningitis? So the potential cause of this meningitis, according to me, is Nesilia meningitidis. So they are saying all of the following about the potential cause of the meningitis in this child is correct. Sorry, they're saying which of the following statement is correct. So they are saying which of the following statement is correct about the potential cause of the meningitis in this child. So the potential cause of meningitis in this child is Nesilia meningitidis. So now what you have to see is, out of A, B, C, D, which is the correct statement about Nesilia meningitidis. Statement A says commonly seen cause of neonatal meningitis. Now please remember, although Nesilia meningitidis or meningococcus is a very important cause of meningitis in children, but usually occurs in children more than 2 years of age. It's very rare to have Nesilia meningitidis in young children, more so very rare in neonates. Neonatal meningitis is more commonly due to causes such as Group B Streptococcus, Enterobacteriaceae. Especially in India, E. coli and Klebsiella are very important causes of neonatal meningitis. Then even Staph aureus is a very important cause of neonatal meningitis. Listeria monocytosis. This again is a very important cause of neonatal meningitis. But Nesilia meningitidis is usually not a known cause of neonatal meningitis. So statement A, according to me, is a wrong statement. Coming to statement B, potentially a gram-positive bacteria. This is a gram-negative bacteria. Nesilia meningitidis is a gram-negative bacteria. It's not a gram-positive bacteria. So that makes choice B, option B, also as an incorrect statement. Coming to option C. Option C says chemoprophylaxis is mandatory for all household contacts. Now, Nesilia meningitidis is a common commensal in the nasopharynx, and it is known to spread from one person to another person, especially through the oral secretions. So it is indeed true that all the household contacts should be protected, because this infection can get very easily transferred, especially through oral secretions, from one person to another. And that is the reason why, if any index child is diagnosed with meningitis, the household contacts should receive chemoprophylaxis with rifampicin. So chemoprophylaxis with rifampicin. 10 milligrams per kg per dose twice daily for 2 days should be recommended in all the household contacts of a child with Nesilia meningitidis infection. So C, in fact, is the correct statement. You need to give chemoprophylaxis, otherwise the risk of transmitting this infection from one child to another child or to other members of the family is very high. All the household contacts have a very, very high risk of developing this infection. So C, according to me, appears to be a correct statement. And if you come to choice D, option D, cephalosporins should be avoided in the management. In fact, cephalosporins are the drug of choice in the management of these cases, especially the third generation cephalosporins. The third generation cephalosporins are actually the drug of choice in these children. And in places where the child is not responding to third generation cephalosporins or beta lactam resistance is very high, you might add vancomycin also in the management. Basically, meningococcemia is an infection which very rapidly spreads to shock, septic shock. Fulminant meningococcemia often is associated with rapid progression towards septic shock, and these children often have these non-blanching or purpuric rashes all over the body, which is sometimes also called as purpura fulminans. So what is purpura fulminans? It is non-blanching or purpuric rashes which are seen in children who have a fulminant form of meningococcemia. And these children very rapidly spread or very rapidly progress to septic shock. So this is a very dangerous infection which can cause meningitis, but at the same time can lead to a fulminant meningococcemia and a septic shock as well. So anytime they ask you a question, a child who has meningitis, along with this the child has purpuric rashes or the child has non-blanch rashes and has rapidly progressed to septic shock, what should be the most plausible cause of this meningitis? It should be Nesilia meningitidis. And the treatment of choice should always be third generation cephalosporins. Vancomycin may be added in case there is a high degree of beta lactam resistance, but otherwise third generation cephalosporins are the drug of choice. Complications of meningococcemia should also be known to you. Complications of Nesilia meningitidis infection. So one of the most important complication of Neisseria meningitidis infection is focal skin infarction. So this focal skin infarction, especially of the lower limbs, is very important. In fact, it may require skin grafting. Then, like meningitis secondary to streptococcus pneumonia or meningitis secondary to Haemophilus influenza, meningitis occurring after a meningococcal infection can also be associated with the development of sensorineural deafness. That's another complication that you should be aware of when you're dealing with a meningococcal meningitis case. Endophthalmitis, arthritis. Then how can we forget about adrenal hemorrhages? Adrenal hemorrhages are again a very dreadful complication which is associated with Neisseria meningitidis. So you should be aware of these complications when you're dealing with a child of meningococcal meningitis. So three things that suggest meningococcal meningitis here. First thing, the child has meningitis and has rapidly progressed to septic shock. Second thing, the child is having petechiae. And the third thing, the presentation findings confirm a child with septic shock, especially with a prolonged capillary refill time, thready pulse, everything which confirms that the child is actually in a state of shock. Shock, meningitis, purpuric rashes, they all fit together under a meningococcal infection. Let us come now to question number 3. Now question number 3 is a question on milestones, and we should always, I keep on telling this in my classes, please go through the milestones. You can always have milestones in the exams as questions. In fact, you have been regularly having every year questions on milestones, almost every year. in INSC exam or in the NEET PG exams, or sometimes in both. So this question is saying the following are a list of some developmental milestones and age when these milestones are first attained in the child. So they have given 4 milestones: turning each page of a book individually, complete bowel control is achieved, jargons, and radial palmar grasp. And then they have given the age of onset of some of these milestones. Now the question that is being asked is which of these milestones is incorrectly matched with the age at which it is first attained. So out of the options A, B, C and D, which is the milestone which has been incorrectly matched with its age? Let us go one by one. A option says 1C, which means turning each page of a book individually appears at 2 years. This is correct statement. There is nothing incorrect about it. The child turns each page of a book individually at the age of 2 years only. Let us come to option B. Option B says 2A. Option B says 2A. 2A means a complete bowel control is achieved at 4 years, which is again a correct statement. A complete bowel control is achieved at 4 years in a child, while a complete bladder control is achieved at 5 years in a child. That is why never make a diagnosis of enuresis before the age of 5 years, and never make a diagnosis of encopresis before the age of 4 years, because a complete bladder control is achieved at 5 years and a complete bowel control is achieved at 4 years. The next milestone is 3B. 3B means jargons is achieved at the age of 15 months. This again is a correct statement. The child first starts speaking meaningful words at the age of about 9 months when he is producing bisyllables. 9 to 10 months. So a 1-year-old child can speak about 2 to 3 words with a meaning. Now, as the age of the child goes on increasing, the number of meaningful words in the vocabulary of the child goes on increasing. At 15 months, a child can speak about 4 to 10 words with a meaning. And at 15 months, the child is able to jargon. But when does the child form sentences? The child forms sentences at the age of 2 years. So jargons at the age of 15 months is a correct statement. Only thing that is incorrect is the radial palmar grasp. This is incorrect. Radial palmar grasp. So radial palmar grasp, they are saying 4D. 4D means radial palmar grasp is achieved at 6 months. This is incorrect statement. It's the ulnar grasp which is achieved at 6 to 7 months. Then the radial grasp which is achieved at 8 to 9 months. Then the pincer grasp which is achieved at 9 months. And a mature pincer grasp which is achieved at 12 months. So ulnar grasp achieved at 6 to 7 months. Radial grasp achieved at 8 to 9 months. Then the pincer grasp is achieved at 9 months. And a mature pincer grasp which is achieved at 12 months. So which milestone is incorrectly matched? It's milestone D, which is incorrectly matched. Radial palmar grasp is first achieved at the age of about 8 months and is not achieved at the age of 6 months. Rest all the milestones are correctly matched. Let us now come to question number 4. Question number 4 says, a 36-week preterm child had breathing difficulty shortly after birth. So the child is a 36-week preterm child and the child has been having breathing difficulty shortly after birth. The child had tachypnea, grunting, nasal flaring and subcostal retractions. Which among these options is the likely pathophysiological mechanism? So they are asking which of these options is the likely pathophysiological mechanisms underlying the most common cause of respiratory distress at this gestational period. So many of the students are likely to say that since this child is a preterm child, any child born earlier than 37 weeks of gestation, will be a preterm child. So many students are likely to say that since this is a preterm child, the most common cause of respiratory distress in a preterm child is hyaline membrane disease or a respiratory distress syndrome. So surfactant deficiency should be the answer here. But this is incorrect. The reason is that this child, although a preterm child, will be called as a late preterm child. And the most common cause of respiratory distress, in late preterms as well as in terms is transient tachypnea of the newborn. It's the most common cause of respiratory distress in preterms, especially preterms who are born earlier than 35 weeks of gestation. In them, the most common cause of respiratory distress syndrome. And hyaline membrane disease is the other name for respiratory distress syndrome. So respiratory distress syndrome or hyaline membrane disease normally occurs in those preterms who are born earlier than 34 to 35 weeks of gestation. And that is because of surfactant deficiency. The peak surfactant production occurs at about 34 to 35 weeks of gestation. So any newborn who is born or delivered earlier than 35 weeks will not have that peak surfactant production of surfactant and is therefore likely to have surfactant deficiency. But the most common cause of respiratory distress is late preterms. Any child who is born at 35 weeks or 36 weeks gestation will be called as late preterm. Any child who is born between 32 to 34 weeks of gestation will be called as moderate preterm. Children who are born earlier than 32 weeks of gestation will be called as early preterm children. And children who are born even earlier than 28 weeks of gestation, they will be called as extreme preterm or extreme premature children. So a child who is born at 35 to 36 weeks of gestation will be called as a late preterm child. He is born just before his term gestation. For him or for her, the most common cause of respiratory distress will not be surfactant deficiency, because by 35 weeks, peak surfactant production has already started to occur. So the most common cause of respiratory distress in a late preterm child cannot be surfactant deficiency, but is likely to be fluid retention in the lungs after birth. The fetal fluid, which normally remains in the lungs in the fetal life and should be removed after birth, that remains for a longer period after birth and usually disappears or usually gets absorbed by about 72 hours, 48 to 72 hours after birth, leading to a transient breathing difficulty in the next 2 to 3 days after birth, which is called as a transient tachypnea of the newborn. So what is the cause of transient tachypnea of the newborn? TTNB is transient tachypnea of the newborn. And the cause of transient tachypnea of the newborn is usually persistence of the fetal lung fluid even after birth. Actually, it is related to the presence of these epithelial sodium channels. There are certain epithelial sodium channels as well as the functioning of the sodium potassium ATPase pumps. Which actually helps in the movement of the fluid. Out in the fetal life just before birth. So the expression of these epithelial sodium channels, which help in sodium reabsorption, and also the function of the sodium ATPase pumps. So they are helping in the sodium reabsorption from the lung interstitium, and that helps in the movement of water also out of the lung interstitium just before birth. Less expression of these channels or these receptors, sodium epithelial receptors, and less activity of the sodium potassium ATPase pump will cause the persistence of the fetal lung fluid even after birth, which is what is known to result in a transient tachypnea of the newborn. And we call it as transient because it usually is only a transient breathing difficulty in most cases, which will get resolved by 48 to 72 hours. The child may have some degree of respiratory distress, fast breathing, grunting, nasal flaring just after birth, but most of these symptoms start getting eased out or start getting resolved, and they disappear usually in 48 to 72 hours time. Some degree of oxygen desaturation may be detected in some newborns early after birth, and there have been some reports that albuterol or salbutamol, as they say, nebulization or inhalation, albuterol or salbutamol nebulization or inhalation may increase these sodium epithelial receptors and hence may help in the reabsorption of sodium or reabsorption of water after birth. So salbutamol nebulization after birth may help. If it is done early after birth, it may help in the management of these children or in early recovery from the respiratory distress in these children. But otherwise, mostly it's a disorder which should be managed symptomatically. The X-ray picture I have told in my classes of TTNB is that the child will have fluid in the interlobar fissures, which makes those interlobar fissures very prominent. Some amount of pleural effusion may also be there, but otherwise fluid in the interlobar fissures plus increased hilar markings, which is sometimes also known as a sunburst appearance or a starburst appearance. So what's the most likely pathophysiological mechanism of the respiratory distress in this case? It is persistence of the fetal fluid retention in the lungs after birth, since this is most likely a case of a transient tachypnea of the newborn. Meconium aspirations are more commonly seen in post-term babies after 42 weeks of gestation. So it's not something that you will expect in a 36-week baby. Coming to question number 5. So question number 5 is a question which talks about a 12-year-old child who complains of a sudden onset right flank pain and a red colored urine. So the child has history of a sudden onset hematuria along with right flank pain. When the child is brought in the emergency, the child is evaluated by a pediatric on call who can feel a right flank mass and can also elicit tenderness on the right flank. So what the pediatric on call does is that he evaluates the child in the emergency and he can feel a right sided flank mass, which is most likely an enlarged right kidney. The ultrasound examination is done, which confirms a right renal enlargement, along with a radionuclide study which confirms reduced renal function on the right side. So there is a right renal enlargement and a sudden onset of a right acute renal failure. What can be the cause of sudden onset hematuria, right renal enlargement, and a sudden onset of acute renal failure in a 12-year-old child? So they're asking which of these is the most likely predisposing cause of this renal pathology. A sudden onset unilateral or bilateral renal mass, a sudden onset unilateral or a bilateral renal mass or renal enlargement along with a sudden onset hematuria, according to me, should go in favor of a child having a renal vein thrombosis. If you see the other options, polycystic kidney, why will it first present in a 12-year-old child? Because polycystic kidney, infantile polycystic kidney, if we are talking about, it's something which is a congenital disorder. So it should be present after birth. Right renal calculus. Why will a right renal calculus present so suddenly? A ureteric calculus, because of obstruction, may present suddenly. But a right renal calculus presenting suddenly, that too leading to a very rapid reduced renal functions, I don't think that can be the answer here. Hemolytic uremic syndrome is usually not associated with a renal enlargement. So the best answer, according to me, should have been a renal vein thrombosis. Now, the question is not what the child is having. The question is what can be the most likely predisposing cause. And according to me, the most likely predisposing cause to a renal vein thrombosis is nephrotic syndrome. See, there are two parts of the question. First is based upon the presentation of the child. What disorder is the child having? Second, once you know that the child is having this disorder, what is the most likely predisposing cause of this disorder? So you have to first know what is cause of the symptoms of the child. And as I told you, a unilateral or a bilateral sudden onset renal enlargement along with rapid deterioration of renal functions and a sudden onset hematuria should go in favor of a renal vein thrombosis. And if renal vein thrombosis is what disorder the child is having, the most common cause of renal vein thrombosis in a young child, when I say 12-year-old child, the child is young only. He may be past his first decade of life, but still he is a child. And in children, the most common cause of renal vein thrombosis is nephrotic syndrome. Renal vein thrombosis is very commonly seen condition in newborns also. But in newborns, the cause of renal vein thrombosis are different. For example, asphyxias. For example, dehydration. For example, shock. For example, septicemias. These are common causes of renal vein thrombosis in newborns. But in children, one of the most common causes of renal vein thrombosis is nephrotic syndrome. I've told in my classes that nephrotic syndrome in children is associated with the increased risk of thrombogenic phenomena, increased risk of dehydration also, increased risk of hypoalbuminemia also, increased risk of edema also, increased risk of infections also, increased risk of lipid cholesterol getting increased in the body also. But the problem of renal vein thrombosis in nephrotic syndrome is very common. So renal vein thrombosis can commonly occur as a complication of nephrotic syndrome in children, and it will present with a sudden onset unilateral or bilateral renal enlargement, right or left flank tenderness. It can be bilateral flank tenderness in case it is a bilateral renal enlargement, and there will be a sudden onset hematuria. Deterioration of renal functions very quick. So renal vein thrombosis in a child should always be an indication that search for a nephrotic syndrome if that has not been already diagnosed in the child. How will you make a diagnosis of renal vein thrombosis? You will make a diagnosis obviously by the ultrasound. So Doppler can show you the presence of thrombus, and this thrombus initially is formed in the intrarenal veins. Then it may progress to the main renal vein, and then obviously it may extend into the inferior vena cava also. It's very important to evaluate the renal functions by the radionuclide studies also, which often is decreased or reduced in these cases. Now, the treatment of a renal vein thrombosis, most of the bilateral renal vein thrombosis are treated by giving unfractionated heparin initially along with tissue plasminogen activators. And then this requires continuous anticoagulations. So initially, the child in bilateral renal vein thrombosis needs to be given unfractionated heparin along with a tissue plasminogen activator, followed by a continuous anticoagulation either with unfractionated heparin or with a low molecular weight heparin. On the other hand, unilateral renal vein thrombosis, particularly with extension into the inferior vena cava, may be treated either with unfractionated heparin or it may be treated with low molecular weight heparin. So please remember, this type of a typical presentation that is being shown here, a sudden onset unilateral or bilateral flank mass, tenderness on the flanks, sudden onset hematuria, and rapid deterioration of renal functions in a child should always indicate renal vein thrombosis. And one of the most important predisposing cause for renal vein thrombosis in children is nephrotic syndrome. Let us come now to question number 6. Question number 6 says all of the following grades of proteinuria will not be consistent with a diagnosis of nephrotic syndrome in children, in a 10-year-old child. Which of the following grades of proteinuria will not be consistent? So they have given 4 grades of proteinuria and they are asking which of them is not consistent with a diagnosis of nephrotic syndrome. So nephrotic syndrome, as we all know, is a disorder which is associated with pathological proteinuria. And this pathological proteinuria means high amount of low molecular weight proteins are being lost in the urine. Now this proteinuria, which is loss of proteins in the urine, can actually be found out by a number of methods. One is obviously the standard bedside method that we often use, which is known as the urine dipstick method. So the change in the color of the dipstick can indicate how much of the albumin is passing in the urine. It's more accurate for measuring the levels of albumin. It's a semi-quantitative method which can better find out the levels of albumin, but it's not so reliable finding out the excretion of the other proteins in the urine. So either the results can be negative or it can indicate trace excretion of urine proteins, which means the amount of albumin in the urine is less than 30 milligrams per deciliter. 1 plus proteinuria indicates that the levels of albumin are between 30 to 100 milligrams per deciliter. 2 plus means the levels are between 100 to 300 milligrams per deciliter. 3 plus means 300 to 1000 milligrams per deciliter, and 4 plus means the amount of albumin which is being excreted in the urine is more than 1000 milligrams per deciliter. So it's a semi-quantitative method which can tell you the approximate levels of albumin that is being excreted in the urine. And usually in nephrotic syndrome, we normally get a 3 plus or a flow plus proteinuria by the urine dipstick method. So this is what we see in nephrotic syndrome. Another way by which you can identify pathological proteinuria is a 24-hour urine protein excretion. 24-hour urine protein excretion. Now, normally the urine protein excretion in a normal newborn in 24 hours is less than 4 milligrams per meter square per hour. This is normal. This is normal. Between 4 to 40 milligrams per meter square per hour is increased, but not pathological. So, pathological proteinuria, which again can indicate nephrotic syndrome, is when the urine protein excretion is more than 40 milligrams, more than 40 milligrams per meter square per hour. So this again is an indication of nephrotic syndrome. Or another way of saying pathological proteinuria is urine protein excretion more than 3.5 grams per day. This is also indicative of nephrotic syndrome. Urine protein excretion of more than 3.5 grams per day, or a urine protein excretion more than 40 milligrams per meter square per hour. This is in a 24-hour of urine collection. And the third method, which is the spot urine examination, is when you find out the urine protein is to creatinine ratio. And normal urine protein is to creatinine ratio is less than 0.2. So normal urine protein creatinine ratio is less than 0.2. 0.2, less than 0.2 in children who are more than 2 years of age. Otherwise, in children who are less than 2 years of age, the normal protein is to creatinine ratio is less than 0.5 in less than 2-year children. But in more than 2-year children, the normal urine protein to creatinine ratio is less than 0.2. 0.2 to 2 protein to creatinine ratio is considered to be increased but is not pathological. So next is, what is the level of pathological proteinuria? So pathological proteinuria is when the urine protein excretion is more than 2. So this is again indicative of nephrotic syndrome. Pathological proteinuria indicating urine protein to creatinine ratio of more than 2. So these are the levels of proteinuria where you can say that the child may have a nephrotic syndrome. Urine protein to creatinine ratio of more than 2, 24-hour protein excretion in the urine more than 3.5 grams per day or more than 40 milligrams per meter square per hour, and by urine dipstick method either 3 plus or 4 plus. So these will indicate that the child may have pathological proteinuria, which indicates nephrotic syndrome. Now let us come to the options. He is saying which of the following grades of proteinuria will not be consistent. So A, urine dipstick method 4 plus, I said it is consistent. B, urine protein excretion more than 3.5 grams per day, I told you is consistent. Urine protein excretion more than 40 milligram per meter square per hour is consistent. This is not consistent. As I told you, a urine protein to creatinine ratio of more than 2 is consistent, not more than 1.5. So question number 6, the best answer is choice D. Let us now come to question number 7. Now question number 7 says, in a 2.5-year-old boy with a known diagnosis of Kawasaki's disease and who is currently on treatment, which of the following is an unlikely short or long-term complication of Kawasaki's disease, splenic ruptures, Ray syndrome, myocardial infarctions, and sudden deaths. Now, Kawasaki's disease is another important topic for your exams, and this is considered to be one of the most common types of vasculitis of childhood. If not the most common, definitely one of the most common types of vasculitis of childhood, along with Hinoch-Schönlein purpura. But the difference is that while Hinoch-Schönlein purpura is primarily a small vessel vasculitis of childhood, Kawasaki's disease is a medium vessel vasculitis of childhood with a predisposition to affect the coronary arteries. So Kawasaki's disease has emerged as a very important cause of an acquired heart disease in children. Without going into too much of details, Kawasaki's disease, the diagnosis can be made when a child has a temperature of more than equal to 38.3 degrees centigrade. And this fever may last for around 5 days to as long as 14 days. Along with this, there are 5 features or 5 criteria which can support a diagnosis of Kawasaki's disease. First is the bilateral non-exudative conjunctivitis. The second is unilateral, more commonly than bilateral, non-suppurative lymphadenopathy, non-suppurative cervical lymphadenopathy. The cervical lymph nodes becoming more than 1.5 centimeters in size. The third is the presence of a rash. The fourth is typical oral mucosa changes, including inflammation of the lips, inflammation of the tongue, where the tongue becomes deep red, which is called as a strawberry tongue, and then presence of swelling, edema, along with the redness of the hands and feet, followed by the peeling of skin from the hands and feet. So these are the criteria for the diagnosis of Kawasaki's disease. Now, in Kawasaki's disease, the thing that you need to remember is that because of the predilection to affect the coronary arteries, you have to put these children on antithrombotic agents. And aspirin need to be given for prolonged periods of time. So normally you start treatment by giving intravenous immunoglobulins, 1 dose. But along with this, aspirin is normally started. The initial dose that you give for aspirin in these children is usually a moderate to high dose, which may range from around 50 to almost around 100 milligrams per kg per day. And this dose will be the anti-inflammatory dose of aspirin. But once the fever subsides, which usually subsides by the second week, then you have to reduce down the aspirin dose and give it for almost around 8 weeks, 6 to 8 weeks in low antithrombotic doses, 3 to 5 milligrams per kg per day. So aspirin is being given in low thrombotic doses, antithrombotic doses, 3 to 5 milligrams per kg per day. Now, since you are giving aspirins for long period of time in these children, there is a definitive risk of Ray syndrome, because Ray syndrome, as you must be knowing very well, is a disorder or a problem that is associated with the use of salicylates such as aspirin in children with some viral infections, particularly with influenza and chickenpox infection. So during influenza or chickenpox infection, if you give aspirin, it can lead to mitochondrial dysfunction, inhibition of beta oxidation of fatty acids, which can increase the levels of ammonia and can lead to a non-inflammatory encephalopathy along with fatty liver failure. So because children of Kawasaki's disease are on long-term aspirin treatment, there is a definitive risk of Ray syndrome in these children. And that's the reason why you should always protect these children by giving them vaccines against chickenpox and influenza. So Ray syndrome is definitely a risk that is seen in these children, particularly because aspirin needs to be given for prolonged periods of time in these children. The second definitive risk in myocardial infarction, I just not told you, these children are known to affect the coronary arteries. Thrombus formations is very high in these coronary arteries. And whenever there is a thrombus formation, there is always a risk of not only myocardial infarction but also sudden deaths in these children. So the only complication that is not seen in these children is a splenic rupture. Other than splenic ruptures, Ray's syndrome risk, myocardial infarction risk, sudden death risk, it's always very common, especially because of their predilection to affect the coronary arteries. And because the coronary arteries can get thrombosed, they have to be given aspirins for long periods of time. So splenic rupture is definitely not a complication that is seen in children with Kawasaki's disease. Coming to question number 8. Now question number 8 says a child with a recalcitrant sinusitis, persistent pulmonary infiltrates, nephritis with rapidly progressing renal dysfunction, and a necrotizing granulomatous small vessel vasculitis. Now this is important. A necrotizing granulomatous small vessel vasculitis is most likely to have which of the following combination on antibodies on immunofluorescence? So we are talking about a small vessel vasculitis. Now small vessel vasculitis can either be immune complex mediated small vessel vasculitis, such as Goodpasture syndrome, which occurs more commonly in adults, or Hinoch-Schwann purpura, which occurs in children. It can occur in adults also, but HSP is also seen in children. But there is another type of a small vessel vasculitis which is not associated with immune complexes. So it's also called as a pauci-immune small vessel vasculitis. A pauci-immune. Pauci-immune small vessel vasculitis, which means the immune complexes are minimum. They are characterized by the presence of anti-neutrophilic cytoplasmic antibodies. And there are 3 disorders that come in this category. First is a disorder which is known as granulomatosis with polyangitis. Granulomatosis with polyangitis, which in the past was also called as Wegener's granulomatosis. The second one is microscopic polyangitis. Microscopic polyangitis. And the third is also called as eosinophilic granulomatosis with polyangitis. Eosinophilic granulomatosis with polyangitis, which in the past was also called as the Church-Strauss syndrome. Let us focus on the first two, granulomatosis with polyangitis and microscopic polyangitis. Now both of them are types of necrotizing vasculitis of small vessels. But while granulomatosis with polyangitis is a granulomatosis necrotizing vasculitis, granulomatosis necrotizing vasculitis of the small vessels, microscopic polyangitis is not associated with any granulomas. Second, while in granulomatosis with polyangitis you have upper airway involvement plus you have lower airway involvement plus you have renal involvement, kidney involvement, a granulomatosis with polyangitis only has lower airway involvement and kidney involvement. Usually upper airway involvement is not present in these cases. Now if you come to our question, the child has sinusitis, which is an upper airway involvement. He has pulmonary infiltrates, which is a lower airway involvement, plus he has nephritis, and that too a nephritis which is rapidly progressing to renal dysfunction. So please remember, these pauciimmune vasculitis are one of the most common causes of rapidly progressing glomerulonephritis in children. And because this child additionally has a necrotizing granulomatosis, that is why we will say that this child has which type of small vessel vasculitis? He has a granulomatosis with polyangiitis. He does not have a microscopic polyangiitis. He has granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis, the third one, is associated with refractory asthmas, but that's not what is present in our case. So our patient in this question has a granulomatosis with polyangiitis. Now, 90% of children with granulomatosis with polyangiitis have anti-neutrophilic cytoplasmic antibodies, which on immunofluorescence has a greater amount of cytoplasmic ANCA plus an ANCA with specificity to proteinase 3, anti-PR3. So this is the type of ANCA, anti-neutrophilic cytoplasmic antibodies, that are more commonly seen in GPA, granulomatosis with polyangiitis. They have more commonly cytoplasmic anti-neutrophilic cytoplasmic antibodies with specificity to proteinase 3, PR3, anti-PR3 antigen. On the other hand, microscopic polyangiitis more commonly has predilection to develop not cytoplasmic ANCA, but they have more commonly perinuclear ANCA with specificity to myeloperoxidase antigen. Perinuclear ANCA with specificity to myeloperoxidase antigen. But because our patient has a granulomatosis with polyangiitis, in our patient there should be more of cytoplasmic ANCA with specificity to proteinase 3, PR3 antigen, and therefore the best answer among these options should be option B. Option C, which is predominance of perinuclear ANCA with specificity to myeloperoxidase, is more commonly seen in microscopic polyangiitis. So question number 8, the best answer should be B. So these are different types of small vessel vasculitis in children. Coming to question number 9, the risk of which of these renal pathologies is significantly increased in a child who presents with a congenital renal malformation shown in the picture. So very easy to identify this renal malformation. The lower pole of the two kidneys are fused, and this is typically a horseshoe kidney. This is typically a horseshoe kidney. A horseshoe kidney is a kidney in which the lower poles of the two kidneys are fused. And please remember, a horseshoe kidney increases the risk of developing Wilms tumor. Horseshoe kidneys are very commonly seen in certain conditions, such as it can be seen, I think, in Turner syndrome also. But horseshoe kidney has increased association with Wilms tumor. The risk of Wilms tumor, which is the primary tumor of the kidneys in children, the main malignancy of childhood kidneys, is Wilms tumor. 95% of kidney tumors in children, and these tumors occurs in children less than 5 years of age, they are Wilms tumor. Wilms tumor are very common in young children. I think their age of predominance, when they most commonly occur, is around 2 years to 3 years of age. So in 5 years, first 5 years, many cases of Wilms tumor can be identified. They are very rare in newborns. So the most common tumor of the kidney in newborns is a mesoblastic nephroma. In newborns, the most common tumor of the kidney is a mesoblastic nephroma. But the most common tumor of the kidney seen in infants and children, infants and young children particularly, is Wilms tumor. And the risk of Wilms tumor is quite high in children who have this congenital malformation, which is a horseshoe kidney, because of the typical shape. When the lower pole of the two kidneys are fused, the typical shape is the shape of a horseshoe, hence the name horseshoe kidney. And now we come to the last question, which is a question on dehydration management. This again is a very important topic for your exams, dehydration management. A 8-month-old infant with diarrhea and vomiting since the last 3 days is brought to a pediatrician for evaluation in the OPD. So the child is a 8-month-old infant. The mother informs that the child is intermittently irritable. So this is very important. The child is intermittently irritable, though he is accepting feeds whenever it is given to the child. But he is irritable. On examination, the eyes and the oral mucosa are dry. So this cannot be a child who is having no dehydration. A no dehydration, oral mucosa will be normal. Eyes will appear normal. They will not appear dry. The moment the eyes are appearing dry and oral mucosa is appearing dry, it's definitely a case of either some dehydration or severe dehydration. Now you have to just identify, is it some dehydration or is it severe dehydration? And because the child is irritable, restless, this can be only a some dehydration, because severe dehydration children usually are lethargic, often unconscious. And children with severe dehydration will not be accepting feeds. They will be accepting feeds very poorly. So this is a child who most likely has some dehydration. I have told in my classes, how do you classify dehydration? No dehydration, some dehydration, severe dehydration. And the management of no, some and severe dehydration is using plans A, which is for no dehydration, plan B, which is for some dehydration, plan C, which is for severe dehydration. Now, as you can very clearly see, no dehydration will normally present with an alert child who is drinking water normally, and the eyes will not be dry, eyes will be normal. Skin pinch will immediately go back to its original position. In our patient, the eyes were dry, oral mucosa was dry. So this is definitely a case of either some dehydration, severe dehydration. Now just see the first criteria. A restless or irritable child who is drinking water eagerly is a child with some dehydration. On the other hand, a lethargic or an unconscious child who is not able to drink is a child who has severe dehydration. In our patient, the child was drinking water, he was intermittently irritable. So this makes our patient a case of some dehydration. And for some dehydration, the treatment will be oral rehydration solutions. Normally, you have to maintain the daily requirements of the child. So you have to maintain the daily requirements of the child. Plus, you have to correct the dehydration. And how to correct the dehydration of this child? The correction of the dehydration can be done by giving oral rehydration solution, which is given at the rate of 75 ml per kg over a period of 4 hours. So it is given at a rate of 75 ml per kg over 4 hours. Plus, once the child's dehydration is corrected, you have to maintain the child in a hydrated state. Maintain hydration. In such a way that 10 ml per kg of ORS should be given after each loose stool. So this will prevent the child from going into a dehydration again. So managing some dehydration in children will be usually with oral rehydration solution. Only indication of giving IV fluids in some dehydration is when some dehydration is associated with persistent vomitings. Otherwise, oral fluids are good enough. Maintain the daily requirements, correct the dehydration giving 75 ml per kg of ORS over 4 hours, and once the dehydration is corrected, maintain hydration, because when the child has loose stools, he will go into dehydration again. So after each loose stool, give 10 ml per kg of ORS. Regarding the severe dehydration management, the severe dehydration management is done by IV fluids. And this IV fluids can be given in children less than 1 year or in children more than 1 year. The IV fluid that you prefer in severe dehydration is ringalactate. You can also give normal saline, but you prefer ringalactate. And here 30 ml per kg of ringalactate is given over 1 hour, followed by 70 ml per kg over 5 hours. While in children who are more than 1 year, 30 ml per kg of ringalactate is given over half hour, followed by 70 ml per kg over 2.5 hours. So while you were treating some dehydration with ORS, severe dehydration has to be treated with IV fluids, and you prefer giving ringalactate as the frontline IV fluid, which according to age. So if the child is less than 1 year, give 30 ml per kg of ringalactate over 1 hour, followed by 70 ml per kg over 5 hours. And in case the child is more than 1 year, give 30 ml per kg of ringalactate over half an hour, followed by 70 ml per kg over 2.5 hours. So now if you come back to our question, we have very clearly identified that our patient is a case of some dehydration. And because he is a case of some dehydration, the best answer according to me should be C. ORS 75 ml per kg should be given over 4 hours, plus the feeds of the child should be continued. As these children are accepting orally, the feeds of the child should be continued. Daily requirements should be met. Dehydration should be corrected, and once the dehydration should be corrected, the child should be prevented from going into a dehydration again by giving 10 ml per kg of ORS after each loose stool. So with this, I finish up these 10 questions which I felt are important and high yield topics for your upcoming NEET PG 2022 exams. So your NEET PG is round the corner. I wish you all the best for your NEET PG exams and hope you all get stupendous and very good ranks, and all the diligent hard work that you people have done, the dividends will be paid by getting very good results of these exams. So blessings and best wishes for a very good rank to all of you. Thank you very much from Dr. Pankaj Tikku. Thank you very much and goodbye.